you have crank, and you have passive distraction test. So biceps 1 is described at 90 degrees, and then I'm gonna actually, similar to what I did with G, I just orient them to the motion. So this is the motion that we're gonna be doing, and then I'm gonna have you actively try and bend your elbow. I'm gonna block all degrees of freedom, not only so that she doesn't drift down, she doesn't drift up, and then I'm gonna it's gonna be a make test as she gradually ramps up her pressure, right? And the harder she pulls with her bicep, the harder the long head of the biceps is going to pull at the footprint and its continuity with the labrum, stressing the labrum. Okay. Biceps 2. Let me know if this is at all provocative. So you go from 90 to 120 and you repeat it.
And the positive is pain.
A pain and or again similar to what I had described personally with the standing O'Briens, is you may get a shift, you may get a clunk, you may get a click in combination with the symptoms. Yep. The crank. So in one of my mentors, Dr. Michael Raymond at Duke University, he talks about. I'll never forget it. The combing of the hair because his children watched The Simpsons of like Marge, and he was like, if you ever had to like comb your hair and you were Marge, you'd do this, right? And that's forever sticks in my head in regards to the crank. So I'm gonna block a couple of extra. Yeah, I'll do some on both sides. So I'm gonna come in. I'm gonna approximate, right? And that's gonna push the humeral head into the glenoid. And then I'm gonna comb my hair like I was Marge. Usually in this case, and I will do it here. So I'm gonna have you scoot yourself up maybe 6 inches so the crown of your head is equal with the head of the table. Because I do want to try and get into as much rotation as I possibly can. That's perfect. Yep. And so, yep. And then feet up. Great. So I approximate, and that shift comes more through my hips rather than it does through my arms. And then, so my hands can feel, because if they're busy adding compression, then I can't do it. And so I'm going to bring her up to like R2 or maybe R1 into internal and external rotation. Yeah.
I feel the tension, but okay.
Perfect. Final one. Put your arm, give your arm back here for a second. Passive distraction. I use the example. There's also an active distraction with this one, where you're going to ask someone to turn a light bulb, right? So as you go into pronation and internal rotation, there's a big stretch on the biceps passively, and that pulls on its footprint, right? So you got to go in the opposite direction. So it, I guess, depends on your orientation, but for me, this is going to be a counterclockwise movement with my right arm overhead. So in her case, right, I'm going to bring her up, and you'll kind of get it as you do it. So if I go like this and I do it incorrectly, I'm like, oh man, I'm just like approximating the biceps. I want to be stretching it. So I'm always going to turn away from the midline. And I'm going to, again, it's not enough to do this because that doesn't really tension the bicep. I need a lockout elbow, and then I need to go into my internal rotation. You can see the coupling of my hands to facilitate that. So I've got it locked into pronation. That's not moving, and then I go with my subsequent hand, my more proximal hand. And again, we're looking for provocation, clunk, clicking, something in that superior kind of slap region.
So, are they testing the same thing, those?
Yep, they are all testing the same thing.
Load 1, load 2, is it just more intense? I mean, why would you do all 4?
Yeah, so similar to what I was describing in our standing sequence for our rotator cuff, we've tried to lay it out in a sequential fashion, not only from an ergonomic friendly standpoint, in this case it kind of works that way, but really it's because it's a progressive load on the tissue, right? And so I don't want to start with my most provocative necessarily. I'm going to just incrementally start to get a sensation of like, again, are you apprehensive? No? Great, then I'm going to stress that with my anterior shift, right? I mean, surprise or what have you, and then it's like, okay, you're not necessarily apprehensive, or you are, plus or minus, but then you're going to go into a progressive loading demand, and the psychometric properties of the test also demonstrate this. With the higher overhead you get, the more the specificity increases.
Sorry.
that's fine.
Well, then try it.
Alright, yeah, we'll break it.
Do you want to do posterior
What's that?
labrum in there?
Yeah, do you wanna show that?
Yeah. Also, to that point too, all these tests are, I know, like, typically we think they're provocative, but we also gotta think about, like, if you're not worried about the labrum or the biceps tendon in general, then you can go a little bit farther along and do the ones that have the most like sensitivity tests. So that way you don't, like, you check it off and you don't have to worry about that later. Because that's also the point of going through all these tests is like, you're like, if you're not worried about the biceps tendon, like, test it, make sure of that. Like, so that way you don't have to worry about it later down the road. And would say if it isn't a problem now, but they go through the rehab and then it becomes like an issue, come back and test it again and see like, oh wait, it came up to become an issue. So then that's like why your examination is kind of important in terms of like going through that graded scale as well. So I'm going to talk about the jerk and Kim test. I personally like doing a supine just because I feel like I have a little better like handle on the arm. This is more looking at the posterior inferior border of the labrum. The way I remember them, because they're going to look very similar, is that the like J becomes before K. So the K, like, so J is less provocative, the K one's way like more provocative, and you'll see kind of why. So what you're going to do is, because you're testing the inferior portion of the labrum, you're going to go in this external rotation position, but you're gonna start arm by side, and so this is for the jerk test. You're gonna add an axial load, and you're going to move across with an axial load. Sorry. It's not a very comfortable test, as you can imagine. Now, with the Kim test, it's going to be same thing, but your hand's gonna actually provide the posterior, and you're gonna add an axial. So it's axial plus a posterior load as I go across. That's one, yeah. So that's why I like to usually this one you definitely start with like the jerk before Kim.
So are you pushing down on the head? Where
Yeah, so I'm pushing an axial load through the humerus to through the humerus to the posterior portion of
and
the.
then what's that? Where was the underhand thing though? No way.
I'm basically doing a posterior mobilization
Okay,
of the humeral head.
Okay.
This feels like a scour test.
That's kind of what that's really what you're doing, but for the posterior inferior portion of the labrum.
How do you differentiate if somebody has some, OA in their humerus or
Sure.
How do you differentiate?
Yeah, that's a good question. So when you're thinking about someone like that's, I would categorize that within mobility deficits, likely, because they're probably going to be in this like, either painful or mobility deficit phase. So that's where the stratification for this type of testing probably wouldn't be as appropriate. Yeah.
And also the demographic
Yeah.
of your patient is also going to be a dictator. So like if I'm like 40 years of age and younger and I have a Fuchs injury, I'm more likely going to tear my my labrum versus older than that. The mechanism of injury would be your rotator cuff, right? Just because the tissue changes over time with entropy. And then the second would be the older individual, likely the person that has osteoarthritis is going to be in that older demographic, depending on whether it's secondary or primary osteoarthritis, which, they're usually 40 or post-traumatic or something of like. And then for me, there's really nothing else in the shoulder that mimics the crepitus that you get with arthritis. And so I know I'm talking about it's like the creaking willow, right? And I think we maybe the majority of it, right? Yeah. And so I would recommend or think that you wouldn't make the mistake of misrepresenting crepitus for the click or the pain that you're going to be getting with this test.
It makes sense too, if you're thinking about OA in the joint, you've got some changes in the cartilage too. I mean, you older shoulder, you're gonna have changes all around, the entropy you talk about, so.
True. All right, we'll break those out, supine test, and we'll go from there. All right, 10 minutes.